I'm Dr. Susanna Vanderpool. I'm a neonatal and pediatric clinical pharmacist. A really common question I get from pediatric residents is, when do I use gentamicin for empiric sepsis and when do I use a cephalosporin? And when I want to use a cephalosporin, how do I know which one to pick? So today I'm going to walk you through my personal decision framework to help you decide when to use what antibiotic and why. So the first step is to think about your patient age and location. Are you treating a neonate or a long-term NICU stay patient, or are you treating an infant or child? So less than 28 days of life, or never been home, right, in the NICU long-term, or are you over 28 days of life, admitted to the ED, the floor, or the PICU? So for neonates and NICU patients, gentamicin is going to be your go-to empiric option for gram-negative coverage. A couple of reasons for this. One is that gentamicin has excellent gram-negative coverage. It also provides gram-positive synergy against Listeria and Enterococcus when used with ampicillin, which is really important for NICU patients. And then the third reason is that with appropriate therapeutic drug monitoring, we have a low risk of nephrotoxicity. So gentamicin is really your workhorse. This even includes patients admitted from home who are still under 20 days of life. I would still use gentamicin over cephalosporin. Outside of the clinical scenarios we're going to talk about in a second, the only clinical scenario that I would go with a cephalosporin over gentamicin in this population is if there's a risk factor for resistance. The most common one is that the patient has had prolonged antibiotic exposure. This would put them at higher risk of having an organism that might be gentamicin resistant, and so you can consider a cephalosporin in this case. But remember that in general, cephalosporins should be avoided in neonates and NICU patients. It puts them at risk of increased risk of fungal infections as well as future resistant infections later on, and has a higher risk of anemia, as well as necrotizing enterocolitis and even mortality, particularly with prolonged exposure. So if gentamicin is appropriate, it should be used. In infants and children, again, cephalosporins are going to be more appropriate than gentamicin. And that's really due to differences in pharmacokinetics, as well as microbiology and toxicity risk factors. Once age and location of the patient have guided your baseline choice, the next step is to factor in the clinical scenario. Of note, cefotaxime is unavailable in the United States, so we'll be comparing gentamicin to cefepime, ceftriaxone, and ceftazidime. So those are the cephalosporins that we're going to be considering. The first clinical scenario to think about is, am I concerned for meningitis? If we are concerned for meningitis, then we should avoid gentamicin in our neonatal and NICU population. Gentamicin has very poor CNS penetration. You can still keep it on empirically until you have culture results for gram-positive synergy, but as your baseline gram-negative option, it is not appropriate if you're concerned for meningitis. The other agent you want to avoid in all age groups is ceftazidime. Ceftazidime has poor CNS penetration in neonates, infants, and children, and so it's not appropriate. In neonates, we prefer cefepime. Cefepime has the best penetration into the CSF of the cephalosporins, specifically in this age group, and so that's why it's preferred. Infants and children, cefepime and ceftriaxone have similar CNS penetration, but ceftriaxone is going to be preferred because it has decades-long experience in pediatric meningitis, so we have a lot more data to show that it's effective. So that's the primary reason why it's used. And from an antibiotic stewardship perspective, ceftriaxone is more narrow than cefepime, and so that also makes it a more appealing option. So the next clinical scenario that you want to address is, what is my gram-positive empiric agent that I'm using? For the most part, that's going to be ampicillin. One of the common pitfalls I see with empiric antibiotic selection is that we're using ampicillin, but maybe we're concerned for MSSA. Ampicillin does not cover MSSA. but you can utilize your gram-negative empiric agent to include some MSSA empiric coverage. So if you're concerned for MSSA, you would want to choose either cefepime or ceftriaxone, because these will add some empiric MSSA coverage. Ceftazidime has no gram-positive coverage at all, and so it won't contribute any MSSA coverage to your empiric regimen. So unless you're using vancomycin or something else that covers MSSA, you really want to stick with cefepime or ceftriaxone. Also remember that gentamicin does not cover MSSA. So in neonates, for empiric late onset sepsis therapy, where you definitely want MSSA coverage, I would actually drop the ampicillin and use an anti-staphylococcal penicillin like nafcillin or oxacillin as my empiric regimen and avoid ampicillin altogether. The third clinical scenario to think through is, does my patient have an acute kidney injury? If so, I would avoid gentamicin, of course. Gentamicin has an increased risk of nephrotoxicity, especially if there's baseline kidney injury or if there's gentamicin-induced nephrotoxicity, definitely avoid gentamicin. In neonates, that leaves us with our three options: cefepime, ceftriaxone, and ceftazidime. Similar to what we discussed earlier, cefepime is a good option. You can use ceftazidime as long as you're okay with the fact that ceftazidime does not contribute any gram-positive empiric coverage, right? So no MSSA coverage, but maybe that's okay with you. So ceftazidime would be okay. Ceftriaxone, I would also avoid in this specific clinical scenario for neonates. In the setting of reduced kidney function, ceftriaxone will have increased biliary excretion. This increases neonates' risk to biliary pseudolithiasis and ceftriaxone calcium precipitation. Neonates are the highest risk for this, as they have usually low albumin levels, are at high risk of hyperbilirubinemia, and are often on calcium-containing fluids. And so in this scenario, I would avoid ceftriaxone. In infants and children, if they have any of these risk factors, I would also avoid ceftriaxone, but usually they're at low risk of these, and so ceftriaxone can be used. You can still use ceftazidime, again, if you're okay with no gram-positive additional coverage. And you can use cefepime. For infants and children, considering antibiotic stewardship, ceftriaxone is going to be your kind of best option, and again, as long as you don't have those risk factors for ceftriaxone-associated complications. Thank you so much for watching. If you liked this video, please subscribe and let me know in the comments what topic you'd like me to cover next.